The next session is next lecture is by Dr. Pradeep Patil sir. He's professor in D.Y. Patil Medical College, Kolhapur, and is avid teacher. He's going to tell us about guidelines for treatment of clavicle fractures. Dr. Pradeep Patil.
The time is 8 minutes, is it? Tushar, time is 8 minutes. 10 minutes. Here it is 8 minutes. Yeah, look at the pointer. Pointer. Hmm. You wanna- So good morning. So I'm talking a little about the clavicular fractures. Uh, I will first look backwards and then look forward. What are the newer things that are coming in the clavicular fracture? Everyone knows minimally displaced fractures are treated conservatively. There is no doubt. Here the question is about displaced fracture and what are the conclusions from the various literature. In displaced fracture, the non-union rates are around 15% and the symptomatic malunions are 15 to 20%. So this is a good number of cases who are having problem in a displaced clavicular fractures, and shortening is the main concern that leads to many problems of shoulder and scapula, and it has surgery has a definitive role in some cases. So I'm going to talk on in some of the cases, and we can form a guidelines for the treatment and some of the recent advances. First case, it is a 30-year male patient with road traffic accident with clavicular fracture with head injury. So this was the X-ray taken, and looking at the X-ray, we can think of it is very undisplaced fracture. But when you see the patient clinically, when sitting position, it looks like this. And when you take a stress X-ray, the picture is like this. So always for a clavicular fracture, you should have a stress X-ray as well as X-ray in the both planes. As it is displaced more than 2 centimeter, open reduction was done. That butterfly fragment is fixed and then neutralized with the plate. So this is 1 month post-op X-ray. This is intra-op picture, and this is 1 month post-op X-ray. And these are the clinical range of movements. Another case is a 26-year male with road traffic accident with clavicular fracture. So looking at the X-ray, X-ray looks very simple, but taken in a different angle. So here you can see a lot of comminuted fragments, and you can also see this is a one big comminuted fragment. So that fragment I missed, and when I opened, I found that my plate, the longest plate is around 8 hole. That is not sufficient to span the whole length. So that's why again I have to add the one plate anteriorly, and you have to do a bone grafting also in this case. Another case, this is a 40-year male patient with clavicular fracture. So looking at the X-ray, this fragment is just beneath the skin pointing out, and it's a long spiral. Usually such cases requires open reduction and fixation. The case is straightforward. You have to go inside, reduce the fragment with the clamps and pass a lag screws and neutralize with the plates. So this is the intraoperative picture and postoperative pictures. So another case, 21-year male with polytrauma is having clavicle fracture, open humerus and proximal ulna. In polytrauma patient, it is very advisable to fix all the fracture for early mobilization. Again, it is fixed with interfrac screw and neutralized with the plate. So post-operative pictures all the fractures. So this is another interesting case. The patient came from outside with history of fall and followed by surgery. So looking at the X-ray, this was his clinical picture, and there was a single scar there. So I was worried, what was this? So patient came for the removal of the implant. There is something put inside. But when I took the X-ray, to my surprise, there was nothing inside. So that means the surgeon has gone inside and something tied with something and came out. And ultimately the fracture unites. The purpose is the fracture clavicle unites itself also. So another case is a 2-month-old injury. The is a medical practitioner refused to take treatment initially. Then at the 2 month, this was his presenting picture. Then he decided for open reduction. The fragment was usually displaced, so that was again neutralized with the screw and fixed with the neutralization plate. So these are his X-ray picture and clinical results. So another most other indications are the associated injuries like this. The patient is having fracture dislocation of the humeral head with the clavicular fracture. It is usually better to fix both the fracture to have early mobilization. Some of the cases are also having AC joint injuries. So at the same time, you have to repair both AC joint as well as clavicular fracture. You can treat some patients having scapular fracture. It is one of the good indication to fix the clavicle in a floating shoulder where your glenohumeral angle is very less, and ultimately patient do well after fixing up the bone fragment. Another interesting case of the cyclist was having injury while returning and he had a clavicle fracture, spiral fracture. So he wanted to start the races again. So he insisted for surgery. The surgery was done like this, but here the fracture geometry was such that I have to pass this lag screw from the top to bottom, superior to inferiorly, and over that I have fixed the plate. But in the post, but when he started practicing, due to aero bars, where in aero bars the cyclist has to bend down. So he started developing the ulnar symptoms, and the nerve conduction study in an MR was done. So this screw was actually culprit for that. So these are some of the cases, and these are the pretty simple cases who are very transverse fracture or short oblique fracture, minimally displaced, especially in younger individuals. You can fix it with help of a intramedullary nails. So after that, we can have some guidelines. Clavicle fracture usually minimally displaced should be treated conservatively. In conservative treatment, there is no difference in outcome of when you treat by figure of eight, cuff and collar, strapping on simple. The long-term results are same. While taking X-ray, usually have tendency you diagnose the clavicle fracture on the chest X-ray, plain X-ray, and you decide the plan. Before planning any surgery, you should have at least two X-ray perpendicular to each other, and in one X-ray, your clavicle should look straight like this, and in another X-ray, it should look like yes, so that you can you don't miss any comminuted fragment that will help you and at the time of surgery. Indications I mentioned: the displacement more than 2 centimeter, impending compound, extensive comminution, and associated. So these are some of the indications. So nailing is usually preferred in a transverse fracture, but majority of the time the plates are very commonly used as the fractures are very complex. So some of the tips regarding the drilling: when you drill, especially to prevent the neurovascular injury, when you drill bicortices, there you can have a feeling of both the corpus. So one, you are drilling eccentric, especially when you are using locking screw. You may feel that is one cortex is drilled, and you may go into the soft tissue. This care should be taken. And while drilling, you should do the subperiosteal dissection, use a new drill bit, and use stop and drill technique to prevent injury. So these are the important slide where you can see the various zones of the clavicular fracture. In the red zone, the chances of injuries are very high. So while doing a anterior plating, the red zone has having danger of passing drill from anterior to posteriorly. And when you are doing the plating from the superior, if you are passing this diagonal screw, the chances of injury are more. So you should be very cautious in drilling in that area. And when you look forwards, so these are the some of the plates now are using. Even the companies are different, but anatomically the all plates look similar. So some of the recent changes. So usually clavicle is divided into three parts conventionally, but nowadays this classification, the clavicle divided into five parts, standing from lateral to medial, and usually the clavicular fractures are more common in second and third. So usually you decide you we thought the middle third clavicle are more common. Usually these are mid lateral to the middle third. So exactly these are more common in second and third zone, and in the fourth zone it is a lateral in clavicle fracture. So you can use a definitely lateral in clavicle plates for that fractures. Another important thing, the post retro curve that is present on the lateral end, which is always constant in all the individuals. So it may be short stature or heighted person. This curvature is always constant. What changes is the anterior curve. So that changes according to the patient's height, and the maximum twisting happens in the zone 2. So all these findings has been collectively studied, and they found out these type of plates, different types of the plates, newer plates, especially useful for the clavicular fractures. So this plate there comes in a four sizes. Usually we fix the fracture considering the central one in the at the site of the fracture. But in these plates, your plate starts from this side, and usually depending on the fracture geometry, you extend the plate. And usually these middle screws are combi holes, and these outer are the variable angle holes. So these are the newer in armamentary for you, but very costly. So at the last, to conclude, in displaced fracture, there is a definitive role for fixation in a clavicle fractures, and newer plate designs are really promising but costly. Thank you very much.
Thank you, sir. Any questions for sir? Thank you.